Okay, welcome back, everyone. I hope you all got refreshed from the well-deserved coffee break. And our last speaker of today is, and of the course, is Frank Robben. He's a computer scientist and lawyer, and he's also active as a Belgian representative in various commissions on e-government, e-health, and social security, and so on. So he's going to talk about e-health security.
Okay, thank you. You hear me? Yes, okay. So I guess you had a lot of technical stuff. I will try to explain how we use it. So I'm the CEO of the e-health platform, the Crossroads Bank for Social Security. I will firstly give you the context and what is our vision, because there are several fundamental rights. You have the right to privacy, to security, and so on, but you also have the right to have qualitative healthcare and a good social protection. So how we put in balance these fundamental rights and what types of measures we take on the institutional level, on the structural level, on the organizational level, on the technical level to have this balance. So it will be a concrete testimony of how we do it. So you have here the context. We have in Belgium about 11.7 million citizens. We have about 100,000 healthcare providers and healthcare institutions, physicians, dentists, clinical labs, pharmacists, and so on, hospitals, homes for elderly care, and so on. We have sickness funds that pay the people, that reimburse the people for the costs they have for healthcare. And we have a number of public institutions. We are a quite complex country. We have a federal level, we have regional levels, we have municipalities, and so on. And there are a number of administrations that are active on these several levels. So the e-health platform, so I was asked to do the startup about 12 years ago, is a little institution. It's about 40 people, not more than that. It's a public institution that has as a mission to promote and support a well-organized electronic information exchange between all those actors in order to make it possible that there is quality and continuity of healthcare provision, that patient safety is optimized, that administrative burden for all actors is diminished, and there is support for healthcare policy making, that we call it secondary use of data, that we can use the data about healthcare provision to patients in a pseudonymized or anonymized way to support the policy and the evaluation. Now, of course, we have to do it by guaranteeing, having necessary guarantees related to information security, privacy protection, and also professional secrecy in as far as the healthcare providers are concerned. So we have then concrete tasks, develop a vision and a strategy regarding to e-health as a whole, being the motive for changes, for the implementation of this vision, organizing the cooperation between all those actors, determining standards, specifications for software companies and for those who help healthcare providers to do their work and support them by electronic services, to check whether the software packages comply with those standards and these specifications. It's not only specifications in the area of interoperability, but also in the area of security. We coordinate a number of aspects of information exchange with regard to patient files, electronic care prescriptions. We conceive a platform and operate a platform, I will explain it later on, for the secure information exchange, and we are offering a number of basic services, mainly security services, for free to everyone who cooperates in the sector. We define division of tasks. I will explain it later on, but the objective is that information is always stored at one place in authentic sources, and that everyone who needs it and is entitled to have access to this data can have it in a correct way. We act as an independent trusted third party, so we get data about patients, we anonymize or pseudonymize it and give it to those who want to do research or policy support, and we promote and coordinate programs and projects. So this is the overall architecture. AS means authentic sources, databases that we can rely on, and value-added services are software packages that are available for the users. The users can be healthcare providers, healthcare institutions of all kinds. And so there is no centralized data storage, there is no central database with all health data about all Belgian citizens. That doesn't exist. The data are stored in a decentralized way at the level of the several healthcare providers and healthcare institutions. So when I go to a hospital here in Leuven, they will have an electronic patient file on me at this hospital. But we provide a number of services in order to make it possible that everyone who uses, as a user, the software can access the data in certain conditions that are available in all those authentic sources, in a well-organized and a well-secured way. So in the middle, we have a number of basic services. I will explain some of them later on when I come to the technical part. And these services are services that can be reused by everyone for free. Again, I will explain the system for user and access management, the system for encryption, the system for timestamping, and so on later on. But what is important is that those who develop the software don't have to bother about how solving these problems. They can concentrate on the added value for the users, and we take care of the underlying security, and we offer a number of services to do it. So I will come back on it later, what services, concrete services we offer. So what are the figures today? We have about, we started in 2010. We now had in 2023 about 20.5 billion digital transactions. That means, in average, about 1,600 transactions for every patient, for every citizen a year. That's a lot. Between all healthcare providers that have a therapeutic relationship, I will come back on it later, with the patient. We have one of the basic services is that we have an e-health box. So every healthcare provider, every healthcare institution has a mailbox with embedded encryption. And we have about 118 million messages a year via this e-health box. We have about 36 million documents that are electronic documents, structured electronic documents that are available in the hospitals and that can be accessed by everyone who needs it, again, who has a therapeutic relationship with the patient. The system is based on a consent. We only share data when the patient agrees to do so, and 93.6% of the Belgian citizens have given their informed consent to do it. So it's a system that is really used. You also see that we have electronic prescriptions for drugs, for other types of services. We have an electronic summary, electronic health record for half of the population. That's our main data that are available on allergies, on medication scheme, and so on. They are available in vaults. I will explain it later on. But you see, it's a quite mature system that is really used, and that also has huge advantages on the quality of care, and that saves a lot of money, because we don't have situations anymore where a person goes to a medical doctor today. This doctor takes blood, he sends the patient to a specialist, he comes at the specialist automatically will have access to the results of the analysis of the blood and will not retake blood. So if we have we have in Belgium about 25% of the people have a chronic disease, one or more chronic diseases. If for every person that has a chronic disease, we have one blood examination less a year and one other examination, we save 250 million euros. The cost of the system is 17 million euros. So it's a huge return on investment only on the cost aspects. So I already told you, for us, it's about balances. We use, so the modern technologies can bring enormous benefits and added value, but they must be deployed with the right safeguards. Some people, I'm a lawyer by education, so I have a lot of discussions with lawyers, but say, okay, you have the right to privacy. I say, okay, but you also have the right, as I told you already, to have qualitative care. That's also fundamental right that is in the European Charter of Fundamental Rights, and this is in the Belgian Constitution. So you have to make a balance between them. And this balance has to be based on risk management and data protection by design with a multidisciplinary approach. And I will explain how you do it. I cannot explain everything. You have 80 slides. I will skip some of them. But this is the global vision. I had some use cases how we do it, but I can come back on it later on. So we have a holistic vision on information security, and some basic principles: security, availability, integrity, confidentiality is ensured by a number of measures: structural, no central data storage, decentralized way, institutional, organizational, technical, and other measures. We guarantee that data are only used for the purposes for which the citizens has given a consent. I will explain how we do it later on. That is only accessible to authorized actors. That's quite innovative. If you see the international environment, we have an information security committee that is designated by the parliament. And every data exchange, type of data exchange, has to be authorized by this independent committee. And the health platform checks when there is a concrete exchange of data, whether the conditions of the authorizations are met. So these access authorizations are public, so every citizen can see in what situations, what types of data are exchanged to what other actors and for what purposes. Everything is logged, so afterwards when there is a complaint, but there are nearly no complaints we have, can be checked who has done what, for what purposes, and so on. Every person has access to its own data. So we have a portal in Belgium. Every citizen can see all its health data in all hospitals, in all clinical labs, at the level of the several healthcare providers in an integrated way with single sign-on and in a secured way. And we have a data protection officer, of course, in every institution, not since the GDPR, but a long time before. So, as I told you, a set of measures. First, a number of structural measures, so things that are embedded, measures that are embedded in the architecture. So we didn't choose for a central data storage. There is no central database that contains all health data about all Belgian citizens. It is decentralized. It is kept by those who have a care relationship with the patient. As I told you already, we have a number of basic information security services on user and access management, on encryption, logging, reference directories, and so on, because if you don't have a central database, you need to know where data are available. That's why we have this kind of reference directories. And we have this independent information security committee designated by the parliament. I explained what is the role of this committee. So it's not a supervisory authority as defined by the GDPR. It delivers authorizations to exchange data. The authorizations, the deliberations have normative value. The deliberations are published. They are defining good practices. They are supporting the DPOs. They publish a yearly activity report. And within these authorizations, they will check 4 things. The lawfulness, is the processing serving a legitimate purpose? Are the purposes well defined? The data minimization principle is all data that is exchanged, is that useful? Is that necessary to achieve these purposes? It's designated measures to guarantee the integrity and the confidentiality. And as the deliberations are public, there is transparency for the data subjects, the people about whom data are exchanged, what is done in what situations. I gave you some references, but it's not important here, I suppose, to the legal environment. The GDPR allows member states to create, and there are even other regulations on the European level that will impose it for the member states, to have this kind of committees and to have a legal framework for the exchange of information. Organizational measures. We have this information security department at the level of every healthcare institution, and also for healthcare providers if they are certain capacity. We have minimal information security standards, what we call minimale normen. We cooperate a lot with the Center for Cybersecurity, so our minimal information security standards comply with the cybersecurity fundamentals that are elaborated by the CCB. We have a working party that tries to coordinate with the DPOs of the most important institutions. For me, it's very important that these data protection standards are elaborated in cooperation with the institutions that have to implement it, so that you have buy-in, that is not something that is laid down by a central administration as to implemented by other ones. No, those who want to have to implement it, they are in the working party and we decide it together. We have a system, I will explain it, I will show it, a methodology to do the data protection impact assessments. Again, it's about managing risks. And when a service is put in place, there is what we call a unique file, unique dossier, that describes the whole system and where checks are done that every condition that is laid down in the deliberation of the Information Security Committee is met. We have a yearly assessment of compliance with these minimal standards, so every institution has to do a self-assessment every year and to send it to the Information Security Committee. It's done seriously because if they lie, they have a huge responsibility. And if there are problems, we will, in a preventive way, contact them to see what has to be done. And they have also internal audits with continuous improvement plans that are imposed. So I will skip this, but since 1993, we have a regulation. There is a legal obligation for the most important institutions, the hospitals, to have this kind of security department with a stimulating role, a role of documenting information security related topics, checks on compliance, reports and so on. So it's really something that is embedded in the day-by-day working of the hospitals, you see the roles and so on. The minimal standards, as I told you, are defined in cooperation with these people so that we have buy-in. It's based on international standards, and there are a lot of areas based on ISO 27000 standards. To do it, you can find all these things on our website. You see here the topics that are covered in those security standards. It's about the organization of information security, about security measures for employees and co-workers, for management of company assets, access control, encryption, physical security, operations management, and so on. We have a kind of data classification, and the most sensitive information, of course, has higher levels of protection than other ones. And each type of classification has data handling guidelines related to transport, to using test development, acceptance, authentications, and so on. And we developed a framework, a tool to do this data protection impact assessment. So I will give you, you can download it. It's an Excel sheet, but we have a lot of, we have templates with list of risks so that they don't have to reinvent the wheel. This is based on what is said by the Data Protection Authority, also on the European level. They can indicate what is the severity of the risk. If it occurs, they can have a heat map to check what is done. They can then take measures to limit the risk, and they have a global overview. That means also that it is well documented, and we do it for every service we deliver every 3 years again. So it is really embedded in the project management and the service delivery. Okay, and then some information. Bart asked me to give some more information on the technical stuff. On the basic services that I mentioned in the beginning. So again, it's services that have been elaborated and that are offered by the eHealth platform for free to everyone who participates in the data exchange. And by having these services, the software providers can focus on the added value and don't have to implement this again and again. And I will explain some of them, not all of them. You know what is a portal. I suppose that you know what is a logging system where we know who has done what and so on, but I will concentrate on the ones who are related specifically to security. The first is everyone that is active in the Belgian health sector gets a certificate based on key pairs, a certificate to prove who he is, so that when we have software that contacts the basic services, that uses the basic services of the health platform, that we know that it is someone who is active in the health sector in Belgium. So this is the basis to encrypt and decrypt messages, for instance, in the eHealth box. And it's also a fallback, because security is not only about confidentiality, but also about availability of services. You can imagine we have 20 billion transactions. If this system doesn't work, nobody in Belgium can get a drug, because the pharmacists will not work. They are not able to download the prescriptions. A medical doctor cannot work. So this is really a system that has to be available 24/7 in every time. I will explain it later on how we have this kind of implementation. But we have fallback solutions, methodologies for everyone, for everything that can happen, for every incident that can occur. And this eHealth certificate is also the possibility to authenticate when the normal authentication system with the electronic identity card doesn't work. So that also means that every healthcare provider in Belgium, every healthcare institution knows how to create key pairs, how to use it in a secure way, and that we have public keys of every healthcare provider, healthcare institution that are available. You can have a look if you want to. The second service is a service about user and access management. So we need to be sure, it's 5 steps, we need to be sure that someone who wants to access data, who it is, that's the identification of the user. We need to be sure that the user is the one that he pretends to be. That's authentication of the identity. Yeah? Identification is who are you, authentication is prove me that you are the one you pretend to be. Then you have to check, we have to verify qualification. Is it a medical doctor? Is it a pharmacist? Is it a physiotherapist and so on? We have to verify relationships. Does this medical doctor has a therapeutic relationship with that patient? And then we have to authorize some things that can be done. Again, the rules, who can access what data are defined by this Information Security Committee and laid down in regulation. Of course, if we want to have a system that is used, we have to meet some user expectations. People, citizens, but also medical doctors and so on, want to have single sign-on. They want to have one-time registration of their characteristics, their relationships, their mandates. They don't want to have a huge administrative burden to prove it. As I told you, they want single sign-on across all applications. They want to use it on as much as devices as possible and with a minimal cost for everyone. So I suppose that you know that in Belgium everyone has an electronic identity card since 2000. This is a card that contains 2 keys, one to authenticate the identity and one to sign, electronically sign. So we implemented the user and access management system according to an international standard. It's called XACML. I don't know whether they explained it to you, but it's quite easy. I will give you a concrete use case. So let's say that I went to my general practitioner. In my situation, it's a woman. So she took blood and she sent me to a hospital to have a gastroscopy, to have a look in my stomach. Okay, and I come back 1 week later and she wants to have access to the results of my blood analysis and to the results of the gastroscopy. So the result of the blood analysis is available on a server of the clinical lab, and the result of the gastroscopy, the analysis of my stomach, is available on the server of a hospital. So two different systems. So 10 years ago, when I came back to my general practitioner, she had to look for a credential to get access to the server of the clinical lab, log in, check the document, log out, look for another credential to log into the server of the hospital, look for my gastroscopy, log out. She was busy 10 minutes with her computer, he had 5 minutes for me. Today, how does it work? Everyone who offers an application, a web application or another application, defines the policy about who can access that data in what conditions. The policy is put in a policy repository, can be centralized or decentralized, doesn't matter. So let's say that the clinical lab and the hospital both said, okay, data are available, data can be accessed if it is a medical doctor that has a therapeutic relationship with Frank Robben. So these are the conditions. This is the policy that has been defined by the ones who put at the disposal the application. Okay. Now, I will give you the several steps. My general practitioner has first to say who she is, identification, and prove that she is the one that she pretends to be. So for that purpose, she uses her electronic identity card. She put its PIN code, or that's not my identity card, that's my, okay. She puts it in the reader. She will have a session, 4 hours. So they have single sign-on for every thing. Then she wants to have access to the server of the clinical lab and the hospital. So there is a software component, it's called the policy enforcement point, that intercepts this question and that will open or not open the door to this application. This policy enforcement point will call a policy decision point to check whether the door can be opened or not. The policy decision point will check what is the policy that has to be applied. And then we'll check in authentic sources, databases, whether the conditions are met. If the information is not available in databases, it will ask it to the user to prove it. Okay, but in Belgium we have a database at the level of the Ministry for Public Health, who is a medical doctor in Belgium. We have at the level of the sickness funds, we know who is the medical what general practitioner has a therapeutic relationship with what patient. Okay, so the policy decision point will, we have a unique identification key. We'll check whether the user who wants to access my data, whether she is a medical doctor and whether she has a therapeutic relationship. If so, the policy enforcement point will open the door and they will get access. Single sign-on, if 1 minute later the same user wants to have access to the result of my gastroscopy, let's say that these are the same conditions, so automatically the check will not be redone. The result goes with its kind of token and gets access to the application. Very concretely, my general practitioner, her software knows that I'm coming at 10 o'clock. She has put her identity card in the morning, entered our PIN code. The software will at 5 minutes to 10 consult these databases, and when I enter her room, automatically the 2 results will be available on the screen. The last version, and she don't need to have 10 minutes with her computer and 5 minutes for me. She has 1 minute for her computer and 50 minutes or 40 minutes for me. That is the very concrete, and it's much secure. So I explained to you the working of the system. You can have a look at it. I explained in the slides, the role of the policy enforcement point, policy decision point, policy administration point, and policy information point. Now, in an international context, I'm in France, I have a problem, a medical problem. I'm in a hospital in France. The medical doctor in France wants to have access to my data in Belgium. Big problem today. So we would like to have kind of federated system. If the policy decision point in Belgium doesn't, in Belgium we don't know that a certain person is a medical doctor in France. Okay, so the Belgian policy decision point could contact the French policy decision point to check in their databases whether it is a medical doctor. In their databases or if the medical doctor has a card to prove that he's a medical doctor, it's not important. So e-health data space regulation was accepted 2 months ago during the Belgian presidency. Within 4 years, every software in Europe that is used by a healthcare provider or a healthcare institution will have to meet a number of standards. We try to have this system as a global European system. Again, it's based on European international standards. It's XACML. It exists for, I think, 24 years now. So this is one very concrete. We have for the identification, authentication, we have, I told you that we have classification of data and that the measures have to be, the security measures are defined related to this classification. So we have also classification of means of authentication of the identity. For the most sensitive data, you need to have a two-factor authentication based on a card and a PIN code, or on a mobile device with a PIN code. For the less sensitive data, we can have lower, it can be, we use user ID and a password and so on. I told you that the data are can only be exchanged when there is an informed consent by the citizen. That was a political decision. There are member states of the European Union that have an opt-out. We have an opt-in. So data are not shared when there is no consent. In some other member states, like the Scandinavian countries, you have an opt-out. It is shared unless the person didn't want it. So in Belgium, the system is the patient has to have given his consent. The healthcare provider has to have a therapeutic relationship with the patient. So that's what we check in the authentic sources. Every patient can exclude healthcare providers from accessing his data. Let's say that you have been married with a medical doctor, that you are divorced, that you are not having good relationships anymore, you can exclude them. What data can be accessed by what type of healthcare provider is put in a so-called access matrix. So that gives this scheme. If the healthcare provider is excluded, he doesn't have access. If there is no consent, no access. If there is no therapeutic relationship, no access. And if there is access, only access to those data that are described in the access matrix. So you see, this is a matrix where you have the types of healthcare providers and the types of data. It is indicated who can access what data. Your general practitioner can access all your data, but for instance, the pharmacist cannot access all data, or the physiotherapist cannot access all data. That's determined, again, with the types of healthcare providers and by the Information Security Committee. There is one situation if there is a vital need. If I'm, I go to a hospital and I'm not conscious. It's about life or death. Of course, there can be a system of break the glass, which is locked afterwards. Another concept we have is the circle of trust. We don't want to have an insight on the central level about in the health situation of a patient. If the health platform would know that there is a relationship, therapeutic relationship with an oncologist, for instance, yes, I know then that the patient has a cancer. I don't have to know that. So that's why we implement the concept of the circles of trust. So we define who is responsible to carry out what types of authentication, what types of verification in what situation. So a circle of trust is a group of users of an organization, for instance, an hospital, for which the organization organizes itself a number of information security measures so that other organizations can have reasonable confidence that the information security measures are complied with, and there is no need anymore to control, to check these measures themselves. So we don't know, for instance, we know that there is a therapeutic relationship between a patient and a hospital, but not what healthcare provider in that hospital. That's done locally, because otherwise we would know too much information about the health situation. And we defined a number of criteria So those who want to implement these circles of trust have to meet a number of criteria. They have to guarantee that there is purpose limitation, proportionality. They have to have a user of access management system, a logging system, and so on. So this is a second service. You have the certificates, you have the user and access management system. A third basic service is end-to-end encryption. And we have two situations. We have situations where we know the destiny of information at the moment that the message is sent. And we have a situation where we don't know the destiny. If a medical doctor sends a patient to a specialist, he knows who is the destiny, but when he prescribes a drug, the patient is free to use his to choose his pharmacist. So we don't know at the moment that the prescription is made who will be the pharmacist that has to have access to the prescription. So that's why we created two basic services. The first is based on asymmetric encryption. So I told you that every healthcare provider has a key pair. And that can be used for authentication, and that can be used for encryption. It's even two key pairs, but okay, it's the same system. So there is a generation of the key pair. The public key is stored in a public key repository. The private key is stored in a secure way on the level of the software of the healthcare provider. I told you that the eHealth platform works out standards and checks whether the software complies with those standards. So there are in Belgium about 8 software packages, for instance, for medical, for general practitioners that meet these requirements. We make it public, so medical doctors will not use software that doesn't comply with it. And again, within 4 years, it will be European standards. When a message has to be sent, the one who wants to send information asks for the public key of the destiny, encrypts the message. The encrypted message is sent to the destiny, and the destiny can decrypt it with his own private key. So this is a situation that we have when the recipient, when the destiny is known at the moment that the information is sent. If we don't know it, we use symmetric cryptography, and we have a kind of division of tasks between the place where the encrypted messages are stored and the place where the decryption key is stored. Okay, so let's take the example of a medical doctor that wants to make a prescription for a drug. So he will create a prescription, he will ask for a symmetric key, you will encrypt it, he will put the encrypted message in a database. The decryption key is put in another database, separation of duties. The patient goes to a pharmacist, and the pharmacist will get the encrypted message and will get the decryption key. Okay, after the patient entered his electronic identity card to prove that he wants this pharmacist to have access to his prescription. So you see how the things that you learned, that were explained to you, are used in a pragmatic way to do this. I don't know, I suppose you have also heard about timestamping in your course. We had a problem that a lot of documents have to be signed, legally signed. A medical doctor doesn't want to use his electronic identity card every time he has to sign a document. It doesn't work. If you are in a hospital and you have a medical doctor that has 4 patients, he will not every time log in, log out, enter his card, and so on. It will not be done. So what did we do? We tried to invent a system that was well working. So it's about be sure that someone is responsible for a certain electronic document, that it existed on a given date, and that since then the content has not been changed. So what do? We apply a hashing algorithm. So I prescribe, let's now say I'm in a hospital, and within the hospital there's a prescription of a drug, okay? We want to be sure that there's a prescription before the drug is administered. So the medical doctor, according to the criteria of circles of trust, uses the authentication means that are defined within the hospital, makes a description, his identity is in the description. We apply a hashing algorithm. You know that the hashing algorithm takes a set of characters, takes a document, and transforms this in a senseless set of characters. But if something changes in the initial document, the result will not be the same. The hash code is sent to the eHealth platform. We don't see the content. We don't know what is prescribed, who has prescribed what, and so on. But we send the hash code, and we have a time-stamping service. And we do the time-stamping of this hash code. We keep it. We don't have any content. We keep it. And we send it back. So if 2 months later there's to be checked whether this prescription existed and who is responsible, we can reapply the hashing algorithm to this prescription, to the document. We can check whether the hash code is the same that has been timestamped, and then we are sure that the document has not been changed since then. So this is a global system that can be used in every situation where something has to take responsibility for a document, that we have to guarantee that the document existed at that moment and it has not been changed since then. We also have, that's a little bit more complex, but we have several pseudonymization mechanisms. So the most used situation, it's just a third-party service. People want to do research, but they don't have to know who are the patients. They have to know data, but not the identity of the patient. So we have services where we can pseudonymize data. We also do small cell risk analysis that after the pseudonymization, someone cannot reasonably re-identify the person. But we also have a new service since last year. It's really a situation where we don't know the link between the pseudonym and the identity, and where it is done locally. And there we make it possible that in a database you have the information about the health situation, but not knowing who is the patient, and then you can do research on it. So another service is the reference directory. As I told you, we don't have a central storage of data. They are stored in a decentralized way. So it is important that if someone needs data, that the data can be found there where they are available, and without having information in a centralized way on the health status of a person. So every hospital and every clinical lab in Belgium is connected to a network. We have 4 networks in Belgium: Leuven, Ghent, Brussels, and the Walloon region. Within this reference, every network, we call it a hub. Every network, there is a reference directory that indicates where data are available in the institutions that are connected to that network. Not the content itself, but this patient has a document at that hospital. So when a general practitioner or another healthcare provider wants to access the data, he will check in the reference. We have a meta hub at the level of the eHealth platform. So every hub, every reference has a reference directory to indicate at what places within this network data are available about what patients, not the content themselves, but only the links. And we know in what networks data are available. Why do we do it in 2 levels? Again, we thought about its confidentiality of data. We have hospitals in Belgium that only treat patients with a certain pathology. Melsbrook, it's only multiple sclerosis. Kortenberg, it's also psychiatric patients. If we would know a direct reference to Melsbrook, we know that the patient has multiple sclerosis. We don't want to know it. So Melsbrook and Kortenberg are behind the hub of Leuven. And we only know that there is data available in the network of Leuven. This hub is managed by medical doctors at the Hospital of Leuven that is organizing the network with, amongst others, Melsbrook and Kortenberg. Okay? So a medical doctor who wants to have access, he will find out where data are available and then have a direct contact, end-to-end, with end-to-end encryption, not passing via the e-health network to get the data. And we have also a number of health vaults where data that are not 24/7 available can be put so that data can be accessed. A last service I want, because I see time is running, is the e-health box. I already explained it to you. It's kind of so the hub, meta hub system is a way to have synchronic data exchange. I need the data and I get it immediately. The health box is about asynchronic exchange of data. It's a mailbox with end-to-end encryption based on the certificates and the system that I explained earlier. And then to end, because I told you it's not only about confidentiality, it's also about availability, integrity, and so on. So this is a public website. You can have a look at it. Every service is tested every 10 seconds, end to end. And you can see, I didn't have a screenshot for that, but you can access you can see if there are incidents, and you can also see if there is an incident in a certain service, basic service, what are the value-added services that are impacted. Okay, we have backup procedures. So automatically, when there would be an incident to a several service, the software of the healthcare provider will go to the backup procedure, so that the user doesn't have. It's like when you go to the sea and there's a problem on the highway, you will be sent by another way to do it. It can be a little bit slower, but you will get access. Every intervention done by every of the providers is put on a system so that you can see when there is an intervention and when you can have risk. So it's really public. So when I did this, my minister said, okay, that's dangerous because journalists and so will see what is happening. I see, okay, for me it's to be transparent, and I never have a problem anymore with journalists because they can see when there is a problem, they can see directly what is the problem and when it is solved. Okay, and again, we have business continuity procedures that are tested. We try to eliminate all single points of failure. We have the communication. We also have trainings. And again, within this end-user software, the balance to the business continuity procedures is embedded. When we send a message, automatically it goes to the backup business continuity procedure. Okay, so to conclude, how does it fit together? So we are delivering, we are trying to plan things, we are delivering deliberation, we are setting up these information security departments, we have the security standards, we have the data protection impact assessment, we implement the security measures, we train the people, we check whether the conditions of the information security committee are met. We have the services that we put at the disposal, user and access management, controlling access, organizing encryption, and so on. We check regularly whether these systems are, and we implement additional measures when it is necessary. Okay, so I hope that you got a flavor about how we try to have a good balance between exchanging information that is needed for qualitative healthcare on the one hand, and how we try to have also good systems for information security and data protection. And again, in my opinion, it has to be a holistic approach, technical measures, but also organizational measures, structural measures, and of course legal measures, but I will not explain this. This is not things that solve the problems to do it. And of course, it has to be promoted and implemented by design. So thank you for your attention. If there are some questions, I will try to answer them.
Two questions. Whenever we teach about why is privacy important, of course, like data, health data is very important, and usually the example is like insurance companies, they access it, it's bad, unfair, blah blah. So how much is insurance companies, I guess, like are involved on this? And the second question is, what are the challenges, the future challenges that the system you will be working on, or would you consider this as kind of like the state of the art and that's it?
So, of course, a medical doctor that works for an insurance company doesn't have a therapeutic relationship with the patient. Okay, so he will not get access because not knowing the database as having a typical relationship. Of course, you can have a situation where the same medical doctor has two roles. He's in the morning, he's dealing with patients, and in the afternoon he's working for an insurance company. So this kind of situations, we are very, we look very close to it. You have to know also that the people can see who have accessed their data. Okay, and we don't have a lot of complaints and a lot of problems, but this is a concrete situation that we have had 3-4 times. But then it is very important. So the chairman of the, how do you call it, l'ordre des médecins, the order is member of the Information Security Committee. Then this medical doctor will not be a medical doctor anymore for the same period. We have in the COVID period, I coordinated all the IT system during the COVID period in Belgium. We had a medical doctor that didn't vaccinate patients, but that put them as vaccinated in the vaccination database. I saw in the evening that we had a medical doctor that said that he vaccinated patients from Arlon to Ostend. It is 300 kilometers. He didn't respect you had the first doses, the second doses had to be 3 weeks later. He vaccinated the patients, he said that he vaccinated within 3 days. And he never, how do you call it? He never ordered a vaccine. Okay. So we are not stupid. We see it in our monitoring system. At 6 o'clock in the morning, he was taken to prison. He's not a medical doctor anymore. Okay, so and then when we have this kind of things, you have to act very severely. Before, when we didn't have the electronic system, when he went to the paper archive in hospital, nobody saw it. So if you implement it in the correct way, you can have a higher level of security. The future challenges, yes, we want to have a situation where today when I have a gastroscopy, I get a document as a patient, I don't understand anything. I have to go to my medical doctor to get an explanation. We have about 2,500 best practices that are described. We are using metadata now to connect it to the database with the best practices, so that when I, as a patient, need information, that I have vulgarized information to do it. We want that we have the situation where patients also want to exchange in some situations data with people don't have therapeutic relationship with them. I'm a handicapped person. Every 5 years I have to go to a control doctor to prove that I'm still handicapped. Doesn't make sense in certain situations. So I don't want that this medical doctor has access to all my data, but so we are using solid vaults to make it possible that people can do this. We are also trying to have more, but that would take us too far. We are reorganizing the software packages for periods of care, so that there are other mechanisms. Now, medical doctors are more dealing with patients for a certain pathology and not seeing the patient as a whole. So there are a number of evolutions we still want to support. Other questions?
Monitor if the doctor had a patient in Arlon and one in Ostende the same day, if you do not see the content of the data?
Yes, okay, but I gave the example in the COVID situation. Normally we don't monitor it. Okay. It is, I don't have a problem that a medical doctor sees you in Arlon and the next day in Ostende. That's your free choice. What I was saying is, when a medical doctor has to vaccinate patients and puts in a central database, the vaccination database, that this patient has got a vaccine and he didn't get the vaccine, then we see it in a central database on the level of the database with the vaccines is a central database. Okay? And there we can, of course, see and can analyze. So I didn't see what patient was treated by what medical doctor, but I saw that a medical doctor said that he vaccinated patients once in Arlon and 1 hour later in Ostende. It's not possible to have this distance. So that's what I gave as an example on how we use data that we have. We will not monitor the whole system, but if we have data and we see that something happened that is not correct, then we will intervene. Okay?
And I have another question. The data protection impact assessment.
Yes.
How do you decide how often you do it? As you said, you do it every 3 years. How do you decide if it's 3 years or 1 year?
Yes, what I said is we do it for the e-health platform for every service every 3 years. We give it as a good practice to everyone, but we don't impose it. So it's up to them. We cannot be responsible for the information security in 120 hospitals and 300 clinical labs and so on. What we do is say, okay, that are the good practices. We check beforehand that the software that you use makes use of these basic services that we made public, and you're responsible if you are using a software that is not correct. So I can say, yes, there is another thing. We pay, so there is every medical doctor, every pharmacist, and so gets some money to have an electronic patient file. He doesn't get the money if he doesn't use a software that doesn't meet the requirements. So in practice, the softwares that don't meet the security requirements will not be used anymore. When I started 12 years ago, we had about 32, 35 software packages. Now we have 8. Yes, it's a very good question. I told you, I will not be arrogant, but we had a document 3-4 days ago for the European Commission where we were on top of it, with some other countries like Estonia and so on. It's not. That's why we fought for the European Health Data Space Regulation on the European level during the Belgian presidency. It was not so easy, but in 4 years, you will have standards also on security. And if you don't meet the standards, software packages cannot be sold anymore on the European market. So I think so there is in the health data space regulation, there are 2 things, and that's for me very important. First, Europe, the European Commission, have to have an open source test bench. We don't want that consultants that have to be paid check whether the software is correct. So there is an open source for free test bench for the whole of Europe. Secondly, in the regulation it is put that the European Commission has to deliver a certain number of basic services. And I hope I explained to you with the encryption. I have to send a document to a medical doctor in France. Where do I get this public key to have end-to-end encryption? We will not send it, decrypt it at the border and re-encrypt it with the French key. That we will not do, okay? I explained to you for the user and access management system. I don't know when you are in France and you have your data in Belgium, I don't know whether the one who is asking for your data in France is a medical doctor. So I want to have a policy decision point in France where they can clear that you are a medical, that the one who is asking for your data is a medical doctor in France. So this is a coordination that has to be put in place. Yes, we already have the wallet in Belgium, as you know, and it is put on the highest level. See, MyGov. And of course, wallets, you know EIDAS, EIDAS 2, you also know that not all specifications are available already. but all systems that will have EIDAS 2 level high will be accepted as authentication of the identification. Of course, it's only about identification to prove. EIDAS 2, in my opinion, so it solves the problem of the authentication of the identity and the verification of characteristics, but I didn't really find a standard for checking relationships. And that's a problem, because I don't want to have a situation where every medical doctor in France can access your data, not the one of the insurance company, only the one that has a therapeutic relationship with you. And I want to ask in France that they not only check that he's a medical doctor, but also that they guarantee that he's a medical doctor, that the relationship with that patient, with you.
Okay, we're already a bit over time, so let us thank Frank Robben again for this clarifying presentation.